Hello.
Hey, how you doing?
Fine, thank you.
Good. You getting a good crowd there? You have many people in the auditorium?
Yeah, we have actually. We have.
Okay.
Okay, I'll start sharing from now.
Okay.
Okay, as usual, John, I will text you before.
Okay.
Next week, I will try to get more people into the application.
Okay.
Yeah, I will try to get more people to watch on internet rather than come here. Yeah.
Well, we spread the word in Facebook, so we're getting a fair amount of people.
Yeah. I will manage Dr. Ibrahim Facebook page.
Yeah.
And will share the Zoom link on that.
Yeah. Are there any kids around that love? I mean, there must be some kids that like social media and like medicine. If you know of anyone that wants to help, they're welcome.
Yeah,
Sometimes
sure.
kids like that stuff. They like to help and they want to be involved with something they like.
Yeah.
So
Yeah, actually, in the crowd, we can see a college student, mid student. I will ask them.
okay, yeah. If anyone that want, I'd appreciate it,
Yeah.
and they can be part of the project.
Yeah, sure. Why not? Okay.
And they can learn too. So
Yeah.
okay, let me get doing some promotion here.
Okay. See you after.
I need to get off there on me.
الناس السعودية خليج انجليزي الله يرحمه خليج انجليزي في كل مقام مقال يعني بينزل على البلد يقول بس نفس البلد مش عارف
Assalamu alaikum, مسيكم بالخير. Good evening from here, Amman, Jordan, from the Farah Medical Campus. My name is Ibrahim Sbayah. I am a neurosurgeon and we are transmitting live to our international audience. This is a very famous painting called The Raft of Medusa by this French gentleman back in 1818. Medusa was a flagship of the French Navy, which sank opposite Mauritania. And these are the only people who survived, 15 people. There were more than that, but they ate the dead people so that they can survive. Our presentation today is pediatric tumor in the lateral ventricle, a pediatric case. So we are talking about the lateral ventricle, and this is the lateral ventricle within the skull. Any neurosurgical resident or practicing neurosurgeon must visualize what exactly is the ventricular system in relation to the cella, to the various parts of the brain. So the lateral ventricle is made of the anterior horn, of the body, of the trigone, occipital horn, and the temporal horn. Again, relationship of the lateral ventricle with the third ventricle at the foramen of Monroe, and the aqueductive sylvius to the fourth ventricle. Here you would see two structures. The thalamus outside and inside is the head of the caudate nucleus. Here is again the same thing, ventricle, septum lucidum, and here is the mammillary body, and we have a tract between mammillary and thalamus, and then we have the fornix, the columns of the fornix, the body of the fornix, and the fimbria of the fornix. Ventricles are supplied by blood, of course, like any other structure in the brain, and we have the anterior choroidal artery coming directly from the carotid, and the two posterior choroidal artery coming from the posterior cerebral. One of them is medial to the other, so they are called medial posterior choroidal, lateral posterior choroidal, and of course the anterior choroidal. Anterior choroidal, against all beliefs, supply only the temporal horn, while the posterior choroidal supply most of the ventricular system. Again, if you ask any neurosurgical resident about this anatomy, they have no idea, no clue. If we look at the ventricles from the top, you will see the head of the caudate lying on top of the thalamus, like this, the external capsule. So head of caudate, thalamus. So thalamus is here in the choroidal fissure. Again, we have to imagine where the choroidal arteries are. This is the carotid artery, so the anterior choroidal comes this way to supply the temporal horn, while from the posterior cerebral we have the two medial and lateral choroidal arteries supplying the rest of the ventricular system. Another look here. at the ventricles from above. The lateral ventricle here, the lateral ventricle there, right side, the anterior horn, the body. We come to the trigone, occipital horn, and then the temporal horn. And the choroid plexus, of course, is C-shaped in the choroid fissures. Again, the same picture with more cutting to see or to show the temporal horn. And I challenge if there is any neurosurgical resident who would know what are the relations of the temporal horn to the brain. It's a mystery, they don't know. They just want to know about how to put screws in the cervical area. Again, here we have to remember one important anatomical feature, which is the optic radiation. Optic nerve, and then the chiasm, and then the tract coming to the lateral geniculate body, giving the temporal lobe, and then the optic radiation going to the area 17, 18, 19 in the occipital lobe. And this optic radiation is very much in relation to the ventricular system. It lies in the lateral wall and the inferior wall of the occipital horn, like this. Lateral wall and inferior wall. So optic radiation is very important to remember when you are dealing with the ventricular system, the lateral ventricle. So this is a very beautiful paper about the optic radiations from Italy, how the optic radiation would look in various objects and various patients. Of course, this is tractography. Again, optic nerve, tract, chiasm here, tract, coming to the lateral genicular body, giving the temporal lobe, and then going around to the occipital area. So here you are, temporal, minus lobe, temporal, same thing here. Why am I mentioning this? Because it has very much relation to the surgery you will see. So this optic radiation will be displaced by various tumors. This is intrinsic brain tumor. Because it is intrinsic, it would push the optic radiation, which is here, it would be pushed medially, like this. So it will push it medially. While if you are inside the ventricle, the optic radiation will be pushed laterally. Again, you have to remember the relationship of the various tracts through tractography, whether it is motor or sensory or whatever association fibers. But here you can see with the tractography the optic radiation. If you look at the ventricles from front, coronal view, hemisphere, interhemispheric fissure, corpus callosum, anterior horn of the lateral ventricles, the third ventricle. And of course, the ventricle is very much related to the internal capsule. And one of the questions I asked the neurosurgical residents in the exam is how far is the motor cortex or the internal capsule from the foramen of Monro? And the answer is less than 1 millimeter. Again, anterior view, we have to remember the choroidal artery, how it's supplying the temporal horn, and both the medial and lateral occipital arteries supplying the rest of the ventricles. Our topic for today is intraventricular meningiomas. Are these rare? Yes, they are. 1 to 2% of all meningiomas. What is the commonest meningioma in the brain? It is the parasagittal, it is the cortical. So this composes 1 or 2% of all meningiomas inside the ventricle. In the pediatric group, it's more. And how would you get meningioma inside the ventricle? Because meningioma does not arise from the dura. It arises from the arachnoid. And the arachnoid is part of the choroid plexus. Choroid plexus is inside the ventricle, so you will get intraventricular meningiomas. They attain big size, 2.5 usually at the time of admission or seeing the patient, but they can be as large as 8 centimeters. So meningiomas are related to the choroid plexus, the arachnoid of the choroid plexus. And which is the commonest area for these meningiomas? Lateral ventricles, more than third ventricle, more than the fourth. So most of the tumors of meningiomas, they occur in the lateral ventricle. Which side? Left side more. Why? Nobody knows. which part of the ventricle? Lateral ventricle, trigone, is the most common part. From the trigone, it goes to the posterior horn or the body or the temporal horn, and of course the temporal. Anterior horn, 0. Why? Anterior horn, because there is no choroid plexus. And this study of 72 cases, not of meningiomas, but of ventricular tumors, 72 cases of ventricular tumors, it was common in the trigone. Again, in a study, 46 patients from Turkey, meningiomas constitute only 6 out of the 46. So it is not common, it is rare. In children, 54 cases of lateral ventricular tumors. Of course, you will have all the tumors, but to a lesser extent, the meningiomas. So this is the list of these tumors. Subependymal giant astrocytoma is the commonest, meningioma is less. So whether in adults or in children, it is not a common tumor, but it is a very challenging tumor. Presentation, usually increased intracranial pressure. The commonest is headache. And I have a word about headache. In the Arab world, in this part of the world, in the Arab states, Muslim states, in Asia, we don't take care of the headaches. We deal with it as if it is nothing. The commonest thing that I hear from my patients, yes, I used to have headaches, which are normal headaches, relieved by simple analgesia. Remember, there is nothing called normal headache. If you have headache, there is a cause for it. Visual symptoms, because we are related to the visual tracts, which we mentioned, related to the antenna capsule, get disturbance because of the hydrocephalus, urinary because of the hydrocephalus, seizures. Is it common to have seizures when you have intraventricular? It is very common, actually, up to 30%. And if you are having a tumor in the ventricle, in the dominant hemisphere, then you'll have temporal or parietal manifestations. This is from Al-Mifti book, Meningiomas. He looked at the authors who reported these cases, and he looked at how much the headache was there. It's very high percentage. Manifestations. So epilepsy, preoperative or postoperative. Usually postoperative epilepsy is more, and it could be generalized, it could be focal, it could be complex function. How much the headache was there? It's very high percentage. Is this the only manifestations of intracranial intraventricular meningiomas? No. This paper from Germany, 2007, about fatal hemorrhage from this meningioma. So meningioma was inside the head of a patient who did not recognize that he has a tumor. It bled and caused him to die. Meningiomas, one of the commonest tumors to have hemorrhage. Another paper from China, 2011, again about meningioma that has bled. And they looked into literature and found these authors reporting cases of meningioma that bled inside the ventricle. What about imaging? This is a very interesting case of mine. I think it summarizes all. You can get calcification in 50 to 90% of these tumors. It happens that this patient is from Tafile, and he had this huge calcified meningioma. Maybe because he's from there. When you do angiogram, you are looking for the anterior choroidal and you are looking for the two posterior choroidals. So the blood supply of these lesions usually comes from anterior or from anterior inferior. When you are attacking them, you will not come through the blood supply itself. That's why it is a challenge. This is another paper about the feeding arteries. They enter the tumor anterior or anterior-inferior. This is the tumor, and this is the anterior choroidal artery. If you put this picture for a 6th year neurosurgical resident in Jordan, he would not know anything about it. He would not do it or tail. Because we don't teach them about angiography. This is not for the neurosurgeons. So this is the anterior choroidal. Here, this is the posterior choroidal. You have to know exactly where they are, because if you want to do surgery for them, you have to see them. The other day we reported the orbit. People say, oh, orbit is not for neurosurgeon. It is for neurosurgeon. You will deal with the orbit every time you open the skull of the patient. What about the treatment? No doubt, treatment of choice is surgery. But look at this, mortality before the microscope was very high because it is a challenging kind of surgery. It was reported first as a finding in 1854 by Shaw. Cushing did the first surgery for intraventricular tumor in 1916, and this is a monograph of Walter Dandy in 1933. All these patients died. If you want to do surgery, you have to avoid damage to the sensory tracts, to the optic radiation, and to the white matter interconnectivity. What is this? Let's see. How would you approach the ventricle? Anterior, horn, body, trigone, occipital horn, temporal horn. So you reach each in a different way. Anterior frontal, transcortical, according to the size you would open. This is a very important piece of anatomy to remember. This is the ventricle. If you have a tumor here in the trigone, how would you approach it? Again, there's a beautiful paper about how to approach each part of the ventricles. Again, neurosurgical resident or neurosurgical practicing, you have to imagine the ventricles, where they are and how to reach them, and what are the relationships of these areas. Just in time. Again, people don't know this anatomy, especially when you open the skull, because you open the skull in a small area. So if you open it here, you'll find a piece of the brain, but which part of the brain? Who of the neurosurgical residents in Jordan or the Arab world or in Asia or developing country know the surface anatomy of these lesions? They don't need to, because what he's interested in is to put a sucker to suck the brain and treat the brain as if it is shit. Sorry for the word. So you have to remember the Sylvian fissure, the ascending limb of the Sylvian fissure, this anatomy, the supraangular and the supramarginal and the angular gyri. Because when you open, you will open in this area. And vein of Labey is in your face. Damage this, patient will be hemiplegic, if not dead. Frontal lobe, parietal lobe, occipital lobe, temporal lobe, Sylvian fissure, ascending limb. This is the motor strip, this is sensory strip, and the sulcus in between, supramarginal angular gyrus. Where we open is here. This is shortest distance to the trigone, avoiding important areas. So you go through the brain, through the cortex to reach to the trigone, either through the parietal lobe or the temporal lobe or the frontal lobe, according to where the tumor is, or you go in between the hemispheres, the transcallosal. And when you do the parietal, your corticotomy should be away from the midline. It should avoid the central sulcus. So here you are, transcortical, transparietal, reaching to the trigone of the lateral ventricle. So this is tumor, meningioma, and you will go through this way. So it's called the transcortical. And this is the optic radiation which we spoke about. So you have either to be a little bit low or a little bit above to avoid injury to the optic radiation. Parietal transcortical. This is the superior parietal, middle parietal, so you go this way. Or you go through the temporal area through this way. Or you go in between the hemispheres this way. The same thing, parietal, between the parietal P1 and P2 parietal. Here is transtemporal, T. T means middle gyrus, 3 is the inferior gyrus, so you go through middle gyrus to the trigone. Or, as I said, you go interhemispheric. Some people are extravagant about their approach. They would go this way, tentorial to the other side. I think this is too sophisticated and too complicated to accomplish. Michael McDermott is a very famous meningioma surgeon. He's a meningioma man in San Francisco, and he published this paper about intraventricular meningiomas of different sizes. And he again stressed the important point of the optic radiation. Optic radiation is lateral and inferior to the trigone and to the occipital hole. So you have to be careful about it. This is the interhemispheric. This is the right side. Here is the midline. You go in between the hemispheres. You go and do cortical incision in the corpus callosum and enter into the ventricular system like this. So you have gone interhemispheric. Engelbert Knoss from Vienna, Alexander Bertalanffy from Switzerland and Germany. They published this, and they wrote this chapter of meningioma of the lateral ventricle in Al-Mifti meningioma book, and they again stress the approaches to reach to the trigone. Knoss, of course, is the man who discovered the relationship of the pituitary to the cavernous sinus. The lines, it's called lines of Engelbert Knoss. Again, this paper, as I said, it is the contralateral transfer sign. I don't believe in this extravaganza because it is not needed. From China. You can use the endoscope, the endoscope, yes. This paper from China, again, they went into ventricular cysts. They are good for cysts, no doubt about that. Mark Swedan from Lebanon, who lives in the States, he's a famous man in endoscopy. Again, he used the endoscope extensively to remove such regions like choroid cysts. Here's the foramen of Monroe, this is the choroid plexus, this is the cyst. So endoscopy is one of the armamentarium that we use in our surgery. And this paper by Charla Banki is a female lady with Axel Bernetzky from Mainz in Germany, and they published this paper about surgery with the use of the endoscope. What about radiosurgery? Imagine people using radiosurgery for intraventricular tumor. Let's see what these people, the giants of meningioma, what would they say? Not the Brahimsbeer, the giants of meningiomas. I call myself a meningioma man, but these are giants. William McDermott, Sam al-Mifti, Engelbert Knoss, Alexander Bertalanffy. Radiosurgery is only for those who are not candidates for surgery, period. No matter what they say, you don't use radiosurgery up front. No matter what paper they produce, no matter what jargon they would use. Paper from Japan. Look at this. The title is very interesting. Presumed intraventricular meningioma, because they don't know what it is. Without a biopsy, without anything. This is the tumor. Let's give some embolization. It will get shrink, and then we'll hit it with gamma knife. Absurd kind of thinking. I don't know how these people think. What about this remaining in the head of the patient 5 to 7 years and then turn malignant? Gamma knife radiosurgery for intraventricular meningioma. Again, it is laughable for me. This is the tumor. This is the radiation. Oh, here it is. 3 years after. So what? What have you done? This is the mockery of AHORA. Gamma knife for superficially located meningiomas. Why would you give gamma knife for superficially located? Gamma knife is a good tool. It was made to treat small lesions that are very deep, that cannot be reached by surgery. Why in the hell would you go for these kind of tumors? Yesterday, I came across this, and I had to share it with you. Gamma knife being given to 5 tumors. 5 tumors at the same session.
Big tumors at that.
Bilateral. And each tumor was treated as single lesion for the same amount of money. So 5 lesions,
Contraindicated.
absolutely contraindicated. Absolutely, it defeats the object of radiosurgery.
لا المهم اخذ 55,000 اذا كل واحد
But look at this.
55,000
Why would you treat? Why would you treat this? Why? Tell me, why would you treat? Why would you treat this?
عشان ما يكبرش.
Yes. Look, personal series of mine. I published this paper a long time ago, 2009, with my residents, Amir and Muhammad and Omar. They are very good people and they have gone very far in their discipline. We published this in the Pan-Arab Journal of Neurosurgery. And this was about this Jordanian family with subependymal giant cell astrocytoma. I think we have presented this here. This is the father, this is the mother. Father is okay, mother is a carrier, and these are the 3 children, male children. The elder boy, the middle boy, the young boy, all with these SIGA kind of tumors. So my series 85 to 2018 of intraventricular meningiomas. I'm not talking about intraventricular tumors, I'm talking about intraventricular meningiomas. If I want to mention the intraventricular tumors, I have about 162 third ventricular tumor, and I have more than 350 of lateral ventricular tumors. But if we take just the meningiomas, I have 20 cases. It says the frequency is to get 1 case per year if you have a high volume, which means that in 30, 33 years, I should be getting maximally 20 or 15. And these are common more in females than males. And again, left side was more. Some of these cases which I came across, different kinds of meningiomas. These are actual cases of mine. Now, let's come to the case for tonight. I think we're doing well regarding time. This is a boy, 33-year-old. He came to the hospital in the middle of the night, unconscious, Glasgow Coma scale 8, fixed dilated pupil. No movement at all on the left side. What would you do? Let's see his images quickly. Look at this. This is a dying person. This boy, his leg is in his grave. He is gonna die, except for God's will and wish. Look at the shifts. Look at the pressure on the midbrain. Look at this, very vague tumor. It's very ugly. It's not well defined, it is hazy. But look at the shift it's causing and the hydrocephalus it is causing. What's the treatment? Shunt, no. If you shunt him, he will die on the spot. If you even put external drain, you have to put it very carefully. So the only thing that you can do is surgery. No shunts, no external drain, just go for it. Why? Because if you put external drain here, you will cause more shift. So you go for the kill, for the tumor. Look at this. Midline is far on the other side. But again, this is very hazy, ugly tumor. And of course, the hydrocephalus. Of course, we intubated him and sent him for the MRI. He was not known to have any complaints. Suddenly, he just collapsed at home because of his hydrocephalus and the brain tumor inside. So intubated, ventilated, sent to the MRI, and we got these pictures. Look at this. Look at this. Tena capsule is gone. The whole brainstem, midbrain and the bones shifted. Okay, so what's the differential diagnosis? Of course, we did not come across that boy at 1 o'clock in the morning and say, oh, what's the differential diagnosis? Whatever his differential diagnosis, he needs surgery. But for you now, sitting here at ease, what is the differential diagnosis of this case? Again, people think this is exaggeration. This is the minimum acceptable for anybody practicing anything in relation to the neurology and neurosurgery. You have to have a list of differential diagnoses. I put them as cysts, or encephalic cyst, arachnoid cyst, choroid fissure cyst. People don't know about choroid fissure cyst. They don't exist. Ependymal cyst from the ependymel, a neuroglial cyst, and this is all these patients are patients of mine, except this one, the Zellweger. I know Zellweger, the female actress, exactly. I love the lady. She's beautiful and she's very well acting. But Zellweger, I should remember it, is kind of leukodystrophy. Choroid plexus cyst, epidermoid cyst, colloid cyst. This is one of the largest colloid cysts in the world, and this is one of my patients. And he came with what? With shunt. Disease of the other board, disease of the underdeveloped board. I think everybody should be ashamed of himself to put a shunt unless it is very mandatory. And don't give us excuses that you are alone at night, nobody's there. There are so many million of solutions to do it. But because it is something that you do and take money for, please stop doing it. A good shunt is no shunt. Ependymoma, again, one patient of mine. Subependymoma. Subependymogenous astrocytoma, which we mentioned, the SIGA. Choroid plexus papilloma. I actually presented this case here in this room. Whether it is papilloma or atypical or even cancerous. So not all the choroid plexus are benign. Some of them are malignant. Look at this. Pilocytic astrocytoma, huge. Again, one patient of mine, we could excise it completely because it is pilocytic. There's no radiation, no chemotherapy for that. We'll wait. Okay, so pilocytic astrocytoma grade 2 or highly malignant. Oligodendroglioma, they love this area. What is this? This is chordoid glioma. This is ganglioglioma, and this is ganglioneuroblastoma. As if these pathologies don't exist, so we don't think about them. Brain, we think of a glioma, astrocytoma, medulloblastoma, 3 kind of pathologies. Pituitary adenoma. There are no pathologies there. Abdominal pain, appendix or ovarian cyst. No. So many pathologies, but you don't want to know about them. Neurocytoma, one patient of mine from Sudan. Germinoma, I presented this case to you the other day. PNET, we'll present it next time. Metastasis inside the ventricle, yes. Teratoma, and this is lymphoma. Again, I presented this some time ago. I will revisit that again. We forget about lymphomas. This is a thalamic hemorrhage, and look at this. Who would think that this is an aneurysm? Hydatid cyst, neurocysticercosis, lipoma, tuberculoma. They are there, but you don't want to think about them because that will demand that you go and study and read. And people give their certificate to kill, and they don't even read a word about it. Once they pass the exam, they don't read. They are masters of the art. They are just there to kill people. Yes, of course.
So the reason why we say it's absurd to have treated a presumed lesion with radiosurgery or embolization followed by radiosurgery is that you're burying the evidence. And when the patient dies, he died with brain tumor, which would have been expected, and the patient dies with the evidence buried with him. So these are actual cases, and look at the difference in the approach had you known what was going on. And the only way to have known what was going on would have been to do surgery or the test before surgery to avoid surgery if not necessary. Now, the cysts I'm not going to dwell upon because the treatment is surgical and they're predominantly seen in this age group. However, ependymoma is treated radically differently after surgery. In pediatrics, we try to avoid radiotherapy as much as possible in pediatrics protocols. In adults, these patients would have gotten radiotherapy after surgery. Subependymoma as well, and then a platinum-based chemotherapy, which is integral in the treatment. Glioma was generally with all grades, including grade 4. Those would be treated with optimal surgery and alkylator-based chemotherapy and radiotherapy, depending upon the age group of the patient you're dealing with. Germinoma, which is even with the presentation with brain metastasis, is treated with curative intent, even if it's metastatic from the germ cell, from the testis or the ovaries. But even if they present with metastasis, they're treated with curative intent, and if they present in the CNS as a primary CNS germ cell tumor, that's also treated with curative intent. And the treatment after surgery would be chemotherapy, cisplatin-based with radiotherapy, depending upon the age group that you're talking about. Lymphoma in this age group would necessitate ruling out systemic leukemia or lymphoma with the secondary CNS involvement, and the patients in that case would still be treated with curative intent. Metastases are probably less of an issue in this age group, but it is frequently missed, as are in geometric teratomas. Now, these are actual cases, and the treatment would have been radically different. Now, the myriad of infections, including TB, and we've forgotten that we are living in a part of the world that is endemic for TB. And you miss TB with CNS involvement, the patient simply dies. And all of these would have been masqueraded, or the evidence would have been completely obliterated by radiosurgery, be that following embolization or prior to embolization. And these are actual cases. This is not a mental exercise of what this could have been. We continue hammering this point on a weekly basis, and these mistakes continue to happen on a daily basis.
So it's the middle of the night, maybe 2 o'clock in the morning. And this is when I opened the dura after hyperventilation, after mannitol and steroids and head up, and you know it. Still the brain is bulging out. And the only thing to do is to go for it. Some people would stop and blame the anesthetist. Oh, I have brain edema. This is the anesthetist's fault. It is your fault. It is not the anesthetist's fault. You have to do something about it. And something to do, there is a cyst, and I want to go for it quickly so that I will get some of the fluid out. This way, the only way to save this patient's life. So I allow this fluid, dark yellowish fluid, to come out, and then I come across the tumor. Again, here is the low, this is below, this is above, this is anterior, this is posterior. So we are in the superior temporal area at the junction with the parietal lobe, at the marginal and supramarginal angular gyri. So the tumor here looks okay. I was happy. Oh, there is a good plane of cleavage. It looked ugly. To me, this is not good. And how would you get a frozen section 3 o'clock in the morning in a private hospital? No way. Because by the time the histopathologist would come, the technician would come, God knows that if anybody answers the phone, start to.
In public and university hospitals, no way.
Of course.
But we did frozen section. No. I'm
No,
not saying that.
this is later.
I'm saying the
the banality that prevails.
So as if there is a good plane of cleavage, but then here you see this white matter here, the line of the tumor. I was starting to get disheartened, feeling that this is nasty, but I continued. I will do my best to take as much as I can. The idea of biopsy and, oh, here we are. We decompress the brain, the fluid is out, and we have taken a small piece, let's send it for radiation. This is a crime. When are we going to stop these crimes in the Arab world? A crime that happens every day, maybe 10 times a day, in a country like Jordan or in Syria or the Arab world or the Middle East or in Asian countries. This is against the teaching. And I think the surgeon who sent a patient for radiotherapy after biopsy is as a criminal as the radiotherapist who treat this case. Don't accept these cases. Say, send back to the surgeon, do your surgery properly. So here, started to feel maybe we are not winning here. It's ugly. Look, when we cut it with the scissor, it's hard. Something funny about it. What the hell is this? I don't know. So we are inside the trigon of the lateral ventricle, anterior, posterior, temporal, top of the head. So the temporal horn should be this way, occipital horn should be this way. So I tried to remove as much as I could from this tumor. And just move forward with this. Here at this point, this is the ependym of the ventricle. I start to feel, well, we are losing the battle and not being able to take the rest of the tumor out. Let's do as much as we can and see what the histology is. So this is the trigon, this is the temporal horn, here it is.
الساعة خلصت العملية حكيم هاي.
I can't remember, but it took about 7 hours. This is important. This is feeding artery coming from the posterior choroidal artery. It's a very important step. And I will show you what is the value of this later on. So the brain is slack. We'll see what happens. I will not stop at the histology here. I will proceed and then discuss it later. Of course, we'll put an external drain for nurses, for male and female nurses. External drain is not a drain. It is a neurosurgical hell of a job to do. Don't treat the external drain as a drain. It is something special. If you put it down, patient or CSF will come down and he will die. So this is the initial post-operative MRI. The following day, the following morning, is a good CSF collection here, but still tumor is there. So this was the initial, and this is how we were left. And then started the battle of what to do. I will discuss later. So let's go here for the histology. We waited after the surgery for about 3 months because there were so many speculations and discussions. In Jordan, we have specimen by Dr. Hassan Annab from Jordan Hospital. He reported it as papillary meningioma. Dr. Salah Jitawi reported it as either astroblastoma or ependymoma or papillary meningioma. Dr. Maher Zahir and Raghat Shaka and Dr. Haddad from King Hussein Cancer Center, and I invited the 3 of them. I don't know if any of them is here. they reported mammillary meningioma grade 3. Dr. Abidat, Fatima Abidat, and Ismail Mutalqa from King Abdullah reported as ependymoma, astroblastoma. What would you do with this? Okay, so let's see what our histologists say. Dr. Hassan.
Actually, this case was done in 2005, if I remember, April. So a long time ago. And again, unfortunately, we don't have the slides in the block. By Jordanian law, we are obliged to keep the slides in the block for 10 years. But the reports will be kept indefinitely because they can be filed electronically and they don't take much space. So unfortunately, we don't have the histology of the pictures. But luckily, I write usually good microscopic descriptions. And this is good because, as you can see, it was a highly cellular tumor, and it has diverse morphology, and they appear to be arising from meninges overlying the brain. There were areas of brain invasion and seedlings along the meninges. The tumor cells were slightly variable in size. They were condensed around the blood vessels forming pseudopapillae, and there were occasional mitotic figures. The background was very vascular with scanted hemangioperocytoma-like blood vessels, and there were degenerative changes with excessive hemosiderin. Actually, probably this is what caused this dark color on surgery. Yeah. And there was prominent lymphoplasmatic infiltrate also. So the differential diagnosis by histology was atypical meningioma, ependymoblastoma, vascular tumor, even I thought about the yolk sac tumor. And I did some immune markers. The tumor cells were strongly positive for epithelial membrane antigen, and it showed a membranous pattern of staining, which is typical of meningiomas. They were negative for GFAP, which excludes ependymoma, actually, because ependymomas are very strong. Ependymomas might be positive for epithelial membrane antigen, but they have a very characteristic dot-like positivity, not unlike here, where we have a prominent membranous staining pattern. CD34 was negative also, as well as alpha-fetoprotein, because I thought at that time about yolk sac tumor, where they were all negative. So this provides, for me, favored meningioma. Other diagnoses are unlikely. So I call it a typical meningioma or papillary meningioma. And here, I think I made a mistake. I think I was at that time following the WHO order classification, because in 2000, they put the typical papillary meningioma into the malignant category, which is grade 3. And King Hussein Cancer Center, they were right about it. Now, this is not from the same case, but just to show you, it has a papillary configuration. If you can go to the other view, you can see this is very cellular. And the cells are centered around the blood vessels. Actually, these are not true papillae. They are what we call perivascular pseudopapillae. Probably they take this configuration because the tumor is proliferating rapidly and it exceeds its blood supply. So only the cells around the blood vessels will survive and produce this pattern. And this is also a very prominent pseudopapillae, and you can see that this could be also confused with, for example, choroid plexus tumor, because it is papillary as well. Okay. I think that's it.
Dr. Salah Jitawa, are you around?
Unfortunately, Dr. Maher, his brother died. So.
Yeah, he from me too. Dr. Jitawi from Jitawi lab, he put testoblastoma, papillary ependymoma, papillary meningioma. This is from King Hussein Cancer Center. Dr. Rafat Shaqqa, Dr. Haddad, Dr. Zghayr, they called it papillary meningioma grade 3. From King Abdullah, Dr. Fatima Abidat and Dr. Ismail Mutalqa, they reported this after consultation with Edinburgh in UK, Dr. Colin Smith and Dr. Joseph James Ironside. They said this is peanut. So why not ask people outside? So James Ironside and Colin Smith from Edinburgh called it peanut. Werner Paulus from Münster, Germany, called it meningioma grade 3. Tarek Tihan from University College of San Francisco, he consulted with two friends, Peter Berger and Bernard Schreiter. They called it meningioma or choroid plexus tumor. And the family members took it to Canada and Australia and it came back as meningioma. If you were in my place, what would you do?
So we basically covered all our differential
All the
diagnoses.
differential diagnoses. So I was left with this. Let's see what they have wrote. This is Tihan saying, this is a malignant tumor. This is mesenchymal. Maybe it is meningioma, or maybe it's a choroid plexus tumor. Werner Paulus also said here that you send these slides to Tarek Tihan in San Francisco. He raised the possibility of choroid plexus tumor. Again, here he's speaking about it is not very typical of meningioma. Peter Berger said, I think it will be of great value to complete the surgery. So this is one man who said, Dr. Sbeh, please proceed with another surgery because it looks like a meningioma. And I took this into heart and I operated again. This is a child, 3 years old. Don't give him radiotherapy because you are not sure. So here you are. This is the cavity of the ventricular triangle, and this is the tumor. Now, putting in mind that this could be meningioma, I wanted to remove it completely. No matter what time it takes. This boy, future is in my hands.
So when you stopped the first time around, Professor Speck, what were you thinking?
Malignant, extreme malignant.
Yeah, I know that you were considering malignancy, but I mean, what
Histology?
made you stop as opposed to
I could not find a good plane of cleavage in the medial part where the internal capsule is. I don't want to. Already he's hemiplegic. But look at this. This is the tumor. I could really go around it. I could catch it. Not like the previous time. So good plane of cleavage here. Maybe because I cut the blood supply the first time that I got this. Which is a well-known fact that when you cut their blood supply, they tend to get compact. So I really could find a good plane of cleavage. Stop and central radiotherapy? No. If this is my child, I want some honest surgeon to do his job properly. If we think of this all the time we treat patients, we'll stop doing the crimes we do. Look at this. With plane of cleavage, you can tell where is the tumor, where is the ependymon of the ventricle. So I'm not going to damage anything. I proceeded around the tumor. Oh, this is the tumor. Well defined. I'm cutting it here. It is more of solid rather than friable. Again, I think this is cutting the blood supply first time helped me a lot. So this is the tumor. 3 months. 3 months of agony on what to do.
Did it increase in size during these 3 months?
No, I will show it to you now. No, radical excision, but we've left a big piece also. Simply because we could not reach to the plane of the cleavage medially where the internal capsule is. But here, after cutting the blood supply first time, I can really go around it. Very good plane of cleavage. So I'll stop because eventually we remove the whole tumor. Okay. So this is immediate post-op, the following day. No tumor. No tumor. 2 years later, no chemotherapy, no radiotherapy, no shunt. This is a boy. Young age. 3 years later, of course, the ventricle would remain dilated because there was a huge tumor there. 4 years later, These are actual pictures. 10 years later, look at this. I found him actually 3 days ago and asked him to come to my clinic. Yes, here he is. This is after the second surgery. And I'm looking at him, he's looking at me. I asked him, I want to repeat this. So I look at you, you look at me. To me, no money in the world can give me the satisfaction of this.
This is not the course of malignant tumor.
No, no. I think it was meningioma grade 2, atypical, according to the new classification, which is not malignant. And I think we made the good choice of going again, remove it, and did not give the patient any. Again, I see you. This is before we started. This is when we went for the second surgery, and this is the rest. With this, I finish, and I thank you. Any questions or comments, please? Dr. Asil. Asil, yes, it's a papillary meningioma grade 2. Yes, it's not malignant.
So actually, by default, papillary grade is grade 3.
I know. So we're talking about grade 2, atypical.
Typical grade 2.
Atypical grade 2. Yes.
كان البوست اوبراتيف كورس بعد الفيرست سيرجري يعني بين الفيرست والسكند
Absolutely well. Good.
يعني صحي الولد
صحيح. No hemiplegia.
ليش صحي؟
صحيح immediately the following
بعد
month.
العملية
Yes, absolutely.
فيش له هيميبليجيا
No. His hemiplegia was just compressive. His pupil was compressive, so we just pulled him out of the grave. So, of course, don't leave a patient on a ventilator. We've mentioned this many times.
When you excise the choroid plexus, will it proliferate again or not?
The tumor was arising from the arachnoid of the choroid plexus. But the choroid plexus, you will not deal with it. You will just take the attachment. And it will not make any difference at all, neither in the CSF secretion or the circulation. So,
I'm wondering if, you know, in 2005, we didn't use Ki-67 proliferative index that much. We didn't, it was not even.
Absolutely, it was not used.
Was not used. But did you do it on the, did they do it on any case?
No.
Or? No.
No, they
Would
didn't.
have been helpful to know.
I know.
Yes. So.
Professor Sbey, أول شيء يعطيك العافية. Did you notice after this long follow-up any change in the IQ of this patient?
Actually, yes, he's not brilliant at school, but he is average.
Yeah.
Yeah. Because I think he held his hydrocephalus for some time. And when we went deeply into the matter, he was slow at school before.
Oh.
But again, slow at school in
He's still
Jordan
alive.
is so it's normal. Absolutely normal. Dr. Nisa.
Well, I want to say, if I was the resident of call at that day,
No, you were not.
and came to me with this huge lesion, cystic lesion, I can place EVD. Can we put intra
cystic drainage.
and this?
You can, but this is the solution of the week. It's a solution of the week.
مش ريزيدنت اذا افرض طبيب التخدير ما خدتش الحاله بالليل وانت بمستشفى وزاره الصحه يعني مين بده يمر على دكتور تخدير يفتح كلينيك في الساعه 2 بالليل وزاره الصحه ولا بدي.
This is another another story, Doctor.
Dr. Ray, thank you very much. I have no words to describe your works. But Saturday before last, my first cousin died in one of the health ministry hospital from appendix, and he was 58. They told the family he's fit and well, 58, no medication, and he's old. Same cousin 2002, New Year's Eve night, same cousin, he had the pituitary hemorrhage and apoptosis. He was unconscious at King Abdullah Hospital. When I've asked him to transfer him to Jordan Hospital for Dr. Ibrahim, they said he's not transferable. Glasgow scale is 5. He's nearly dead. I've asked Dr. Ibrahim at that time, can we go and do the surgery there? We went there, something like 6 o'clock, arrived there at 8. We worked, he worked, I anesthetized him, he worked, and he was
survived.
He did survive very well till Saturday before last. He died from an appendix. What I want to say, always it takes two to do either to kill or to do such a good work. Our job is extremely difficult because sometimes you deal with fantastic surgeons. The joy, as you said, the thrill when you see such a patient. Most difficult thing in anesthetist's life to anesthetize somebody who's unconscious, because actually that's our job, to make people unconscious. But to make unconscious, it's extremely difficult because we don't know what to expect afterward. How to you go to make unconscious person unconscious again, and then you don't know what to expect, honestly. But the thrill to see things coming back, but at the same time, the ache, heartache, to anesthetize for mediocres. Unfortunately, I did it. All of us, we did it, like it or not, because this is the country. This is the law. I remember anesthetizing a child, 9-year-old child. He was a dentist child, came from Halab all the way, looking for best care. And I knew the surgeon, he was mediocre. And at 4 o'clock, he said, Allah yarhamu, Allah ta'ala. But really, I would like to thank you. I've seen, I've done so many cases. I have no words.
دكتور معاوية سؤال بعد.
Thanks.
لو هذا المريض انت نايم او انشغل وانت نايم بتصحيه بعد السيرجري هو كان في اوب انكونشس عقله تحاول تصحيه.
Of course, of course.
حاول تصحيه.
Of course, I will.
No patient should stay on a ventilator after surgery. It is the trick of the surgeon, the mediocre surgeons, and there are plenty of them, to cover their crimes. Simple.
Of course, I will.
Simple. So,
الحمد لله يعني انا مر علي حاله زي هيك وتوفى المريض بنفس العمر، وحتى الهيستوباثولوجي كان في كويستشن يعني انه ايش بالضبط الفيجن، بس يعني ده كان اللي هو around the operation، خلينا نحكي يعني around the time of operation، و usually related لانه ما كان في good excision للتيومر بالطريقه الصح. هلا في الحالات اللي قدمتهم اول زي المنجوما الكورتيكال الفولو اب عليها بس سنه ونص.
That's the irony and that's the hypocrisy of this radiosurgery. They publish a paper after 2.5 years. We know that tumors can come back. Usually the figure is 19 years.
Exactly. بس خليني احكي الموضوع شيء كثير مهم. انا اضطريت اكتب محاضره واخذتها من المفتي، وكان الحكي انه في mortality حتى في الكونفكستي منجوما usually related to signs of thrombosis after the operation. This should be discussed يعني بصراحة by committee. The patients who died from their studies take the chance of living another 1 year after exposing to radiotherapy or radiosurgery.
So you are encouraging people to treat this because the surgeon was not good enough and caused severe Come on.
Dr. Ibrahim, please, listen. I'm talking about the Mufti series.
I know I'm Mufti series by heart.
But I want to say, not that. I want to say, emphasizing about there will be a committee deciding which patients.
Of course. When we started, I know your name. When we started here in Jordan, we had a committee made of 20 people. endocrinologist, oncologist, radiotherapist, neurologist, etc. To decide whether this case should be taken or not, because this is the legacy we took from Switzerland, from Stockholm, from Sweden. They had this committee, and it is a world referral center. So everybody referred the cases for them. So they sit, and out of 100 cases, they would choose 1 or 2. But to treat everything
and
across the table,
and putting a selection criteria for people according to their age, according to their comorbidities, who should take advice from this committee before being.
Thank you. I hope that can be done. The other thing, you did not mention the complications of radiosurgery. Would you have superior sagittal sinus thrombosis after radiosurgery? The answer is big yes.
Yes. That's why we should have a committee. At least when a patient dies, no one could be.
Sir, there is no morbidity or mortality here. In the Arab world, in the Asian world, in the underdeveloped, it is put under the carpet. Nobody wants to hear about it. Nobody wants to know the right thing to do. People just are blind. Take a specimen, send for radiotherapy. Put a shunt, send for gamma.
لا حكيم واحد بليز يعني واحد من البورد اكزامينر بالبلد اوكي واي ثينك بتعرفوا انت واحد من معلمينك هلا باراساجيتال مننجوما اوكي بارشال اكسجين تيست تايم الصوره بعد 3 اشهر الام ار اي والله التيومر رد راجع ما هو ما فيش ايرلي بوست ام ار اي التيومر رد راجع بتحكي لي عن انه سجلتها ساينس ثرومبوسيس يوم ما فتح المره الثانيه هو خلع السوبيريور سجلتها ساينس وطلع حكى للاهل برا المقيم برضه ضغط على السوبيريور سجلتها ساينس وتوفى المريض يعني عشان هيك هذا يودي للراديوثيرابي ما علينا.
Any other questions or comments? If not, we thank you. We'll see you next Wednesday.
والله جاب البون هيك مزع الساينس الدم على السقف نشط. بدي اخذ صوره من هلا بدي اخذ صوره اللي فيها البنت بعد بسمع بعد ما يكمل بالله
Can you hear me, Dr. Sabea?
Yes, I can.
Greetings. Thank you for another excellent multidisciplinary presentation, which is unique to your style, and you've been doing it for 27 years. We have a couple of panelists, I think, that may have comments or questions for you. First, Marco Maloney, a neurosurgeon from Italy. Hello, Marco.
Hello, John. Hello, Dr. Ibrahim. I appreciate a lot your presentation, and most of all, if I can, you can allow me your profound heart and passion doing surgery. Is priceless. Is absolutely priceless, even after hours and hours into operating room. My question is just a curiosity. You showed us you put external ventricular drainage after surgery, right? How many days and what criteria do you use to keep and then take out the external ventricular drainage to avoid aseptic meningitis, something like that?
Sure. Every intraventricular surgery, after surgery, I put a drain, whether there is hydrocephalus or not. Because if there is hydrocephalus, you would not know whether the hydrocephalus will continue after surgery. So you have a safety valve. The other thing, if there is no hydrocephalus to start with, you want to drain any CSF for the blood, etc. So I keep it for 2 to 3 days. I'm judging by the clinical picture of the patient, by CSF analysis, by no fever, and by CT scan, just to assess the size of the ventricles. After that, I remove it.
Perfect. Thank you very much, Dr. Ibrahim.
Thank you.
Adnan, do you have any comments or questions?
Assalamu alaikum, Dr. Ibrahim.
Hello.
Well, can you hear? Can't hear you, Adnan. Go ahead.
Hello, Dr. Ibrahim. Assalamu alaikum.
Hello, alaikum salam.
Very good presentation, excellent presentation, and admirable work you have presented. I'm very impressed. And sir, just one question I will ask, which was you were saying about that intraventricular tumor, no one should place any shunt or any EVD before going for surgery, because it can cause a midline shift, and it can increase the midline shift, and it can worsen the patient status. So
Sure.
if we face if we receive such patient in emergency when there is no other option for elective surgery or emergency surgery for that case, so receiving in emergency such patient, what can be done in few hours to save the life of the patient?
Now, across the table, I'm against shunts all my life. I believe a good shunt is no shunt because there is no reason for it unless it is extremely mandatory. So all my life, I've never used a shunt. I can do it. I can do it within 25 minutes from A to Z. I was called the fastest gun in the West as I was training in London because I used to do it very quickly. But it is useless because there are so many other methods for it, especially now with the ventriculostomy and so on. Now, when we are facing an emergency situation like this, if you put external drain on the other side, like in our patient, he had big tumor on the right side, pushing to the other side, ventricles on the left side, put external drain, he will die on spot. The anesthetic will tell you cardiac arrest. So don't. If you cannot proceed with anything, then at least put external drain in the cavity of the cyst, if the tumor is cystic. But what would you do if the tumor is solid? What would you do if you have caused hemorrhage? So we should be able to, and don't tell me that there is no facility, because in every hospital there are senior surgeons and medium surgeons and young surgeons. So get the senior surgeon out of his bed at night to come and operate. In this part of the world, senior surgeons stay at home, they don't deal with the emergency, they delegate it to the most junior, most unexperienced, and they make hell of a job out of it.
Yeah. Sir, one more question about you are saying that colloid cyst, that no one should do any EVD or shunt in colloid cyst.
No, of course not. This is a crime. This is a crime. To put
Because
a
I have
shunt.
seen
I have seen so many.
career, I have seen,
Unilateral
so
shunt and bilateral shunt for colloid.
Yeah,
this is a crime. This is a crime because you can take it out without shunt. If the patient is my child, my daughter, my son, I do not accept to have to for him to live his life with a shunt, blockage of a shunt, revision of the upper end of the shunt, revision of the lower end of the shunt, and so on and so forth. And then one of the residents come with you and say, "Oh, I have my logbook. I have done 300 surgeries. You look what they are. 299 are shunts and revisions of shunts." We have to train neurosurgeons, not mediocre residents.
Sir, thanks a lot once again. Thanks a lot, sir.
Pleasure.
Include one more comment, Dr. Sabea.
Sure.
I'm not a neurosurgeon, but one statistic that really surprised me was that the mortality of this type of meningioma was 40% before microscope.
Right.
I didn't realize that the microscope has such a profound effect on neurosurgery.
Of course. Microscope was introduced into neurosurgery in the early 70s. And the major man who did all the work that we learned from is Yazarji, Muhammad Ghazi Yazarji. He done a lot of microscopic work also from his teachers. But microscope, to me, is mandatory in every neurosurgical procedure, even if you are doing a desk. It is mandatory. And there is no finger removal of the tumor. We stopped doing that. Everybody should stop doing that. But I'll take you back to 100 years ago. Before this, say, beginning of the 20th century, 1900, surgery was done on one patient. And it is in the sense of the surgery that we know, anesthesia and cutting, etc. Of course, anesthesia was using ether. And the mortality rate of that one single patient was 300%. How come? The patient died because there was no penicillin, no antibiotics, nothing. The surgeon cut the finger of his assistant as he was cutting, so the assistant died of gangrene. And one of the observers, he had a heart attack and he just flipped and died. So 300% mortality just 100 years ago. So you can see how far we have gone. But still, our practice is really polluted with these mediocre surgeons who come with ideas that are really strange. They don't treat tumors with gamma knife as upfront as the first line of the treatment. This is because you are a mediocre surgeon. You cannot operate. Gamma knife is a very good tool. I appreciate it. I respect it. I respect Klaus Laxell who invented it. But in his definition, it is one single dose of radiation giving to small, deeply sedated tumor in a patient who cannot go through surgery or he is unfit for surgery. Look at the time now. They are treating 7 and 8 centimeters tumors. They are treating cortical meningiomas. They are doing things which are really absurd simply because they are mediocre surgeons. And we should put the finger in their eyes and say, you are mediocre surgeon.
Okay, thank you, Doc. What is the presentation next week? Do you have a topic yet?
I have not decided yet, but I'm thinking of taking it a little bit lighter. There is a very unusual skull tumor. I'm going to present next time.
Okay, we'll see you next week. Thank you, Doc.
Thank you. Thank you very much indeed. Bye-bye.
Bye, Dr. Abner.
Okay, very good. Hey, Marco, how you doing?
I am pretty fine. I'm a bit tired, but very satisfied.
Yeah, hey, Adnan, how you doing?
Thanks for resolving the issue.
Hey, so how was your vacation? You went to Greek Islands, right? Marco, you went to Greece, right?
In Greece, yeah, for a holiday, just my only week of holiday. But before I was in Rotterdam, Holland.
Right, that was a work, right?
Hands-on course in Skull Base with Dr. Christ from Arkansas.
Which islands did you go to in Greece?
What's the island? Crete.
Oh, Crete! Wow, a lot of mythology, a lot of Greek mythology there.
Yeah,
King Minos.
Yeah, unfortunately we weren't able to visit it because they closed early during the period we were there, so we weren't able to explore the archaeology. But the aims of these holidays was to relax ourselves, me and my girlfriends, because we worked a full week. Yeah, just 1 week.
Oh, okay.
1 week of sun, but to relax and to back to work. And I back very strong. In fact, I suddenly faced a case of a falx meningioma. It was going very, very well.
Really?
Falx,
F-A-L-X, falx meningioma?
Yeah, exactly. You want to show you some picture?
Yeah, sure.
Okay.
Yeah, Dan, you like to see this, right?
Okay, let's see. Sure.
He's going to show some pictures of falx meningioma.
Yeah, a moment. I booked the. Yeah, this is. What? Apple Finder. Okay. Okay, this is the. Oh, moment. Okay. This is the first MRA.
It looks ominous on the CT. It looks terrible, but it's really not that bad, right? A meningioma. Most of the time.
The that was atypical meningioma, second degree. Of recurrence after 5 years. But I was able to remove the wall meningioma. In fact, you can see here the CT scan patient did today is very well already in walking, and it's pretty good. There is some cerebrospinal fluid behind the skin flap, but there is no communication. So I'm hope this collection adsorb during the next days. I hope so. It was pretty. It was totally removed. So it's a Simpson grade 1, and. Of course, in these patients, I'm trying to explore the literature to find if there is some indication about radiotherapy, because some authors tell that atypical meningioma grade 2 need to be irradiated. Other people say the MRI after 3 months and see if there is recurrence, and then operate operating a second time if there is regrowing. So
well, yeah, that area beneath where the meningioma was, is that damaged brain tissue there? The dark area, is that, or just residual from the X-ray or whatever?
No, is in part is brain edema, and all also the meningioma was very intimate with the arachnoid. In fact, I was able to find a plane between brain and meningioma.
Okay.
Usually in meningioma, you have a plane and you follow the arachnoid, and you're able to isolate the meningioma and take it out. In this case, it was only lateral to, you can see here, a moment. Okay, only in this part there was a plane. If I was able to save the brain here, but in all this plane, above all here, there was no arachnoid. Was intimate with the brain, so I need to sacrifice a bit of pia mater here. Fortunately, is a frontal and right side in a patient's right hand side, so the patient is very well, and no deficit, no cognitive alteration. So it was satisfying. I was a little bit sad when I saw, even if it was expected, the histology, because grade 2 obviously is 30% of the recurrence. So the patients need to be keep in touch with us very strongly.
Generally speaking, meningiomas look worse than they really are, right? If I'm not a neurosurgeon, but if I saw that CT, I would think, wow, disaster. But it's really the lining that's tumorous, right? It's not the brain tissue itself, right?
No, is meningioma is from arachnoid origin,
right.
So it's not into the brain like glioma.
Right.
In fact, it is a
tumor.
is a tumor of the capsule of arachnoid. Yeah. In fact, is the most satisfying tumor to treat in surgery, because you're able to save the brain, to operate outside the brain tissue. In this case, of course, it was very intimate with arachnoid, so I wasn't able to have a plane to save. I need to sacrifice the superficial aspect of the brain. But usually in a first degree meningioma, you're able to remove the meningioma and save completely the brain, because you have a plane between the brain and meningioma. That is the arachnoid plane.
Do you have any comments for Marco, Adnan? Comments or questions?
Yeah, I've seen this scan. Very good work done by Dr. Marco.
Okay.
Thank you.
Meningioma, as he explained, that it arises from the meninges. So usually brain parenchymal tissue are intact, and that hypodense area after the surgery he was showing it could be due to the long-term ischemic area developed, or the pressure on the brain parenchymal tissues. So it will not give the normal aspect as other components of brain parts. So, very good. Yeah.
Thanks.
Okay, very good. Okay, guys. Friday, no, we don't have a webinar until Saturday. The African kids have one, and I'll let you guys know. You're both welcome to come.
Okay, thanks. Thanks, Dr. John. One question more. Last time I was asked to add me in your email list. Still, I cannot receive any email.
Oh, okay. I tell you what. Let me do it. Let me do it again. Sometimes I forget. Okay, just put it in the chat box right here.
Okay, I send you my email ID, please. And what was the issue today? I was not able to.
Well, you know, Marco, you mentioned that too. They're starting to ask for passwords. That's new.
Yes,
Marco, for Zoom, you had to get a password to get in.
He asked me a password.
Well, that's new. I've got to talk to them and say, what's going on here? This is new, because I think a lot of people, when they see that, they just go away. They don't come in. because I'm not prepared. I should put.
Not join.
What's
That
that?
was, yeah.
You couldn't enter at all, right, Adnan?
It was strange. I at first I think it was because I'm operating another PC, another computer. Is a Mac, and a new buy for me. So I download the Apple version of Zoom. So I thought maybe there is something different from the personal computer.
Oh, okay. But I haven't heard of this issue. Adnan, it asked you, you have Apple too? You use Apple?
No. I'm using the simple.
Oh, okay. So it's not particular to Apple then.
Yeah,
Okay.
last time when I was connecting and it was easy to access from anywhere, from through web or through application. But this time I was facing difficulty. So I think today we have not other panelists as Dr. Khalif and other people. They usually come for every presentation.
Yeah, I
But they
think
today,
someone else after the presentation, someone said I couldn't get in because, of course, during the presentation, I don't notice it sometimes that someone sends me a message, but someone did remark that they couldn't get in. I think it was Khalif. They couldn't get in the last time, because. So I guess I'm going to talk to Zoom and say, what's going on? You guys are putting new stuff that's making it harder. Now not only have to put the Zoom link and the smartphone webinar number, but now the password too. But if we have to do it, we'll just do it. That's all. I just gotta. That's my job, is to keep up with developments like that.
thanks a lot. You are doing a wonderful job for us.
Oh, it's fun. It's fun. It's when it goes well. I tell you, Marco, we had a fantastic webinar. Women's neurosurgery on neurosurgical complications. It really went well. We had 7 presentations, but after it was over, we edited it right away, and all 7 we separated. So they all have their own. When you present at a conference, you don't expect to have a video of your presentation. Well, we're giving people their presentation of when they presented it. And of course, you got to love that if you present. It's nice to have something to show for your efforts. So we're able to give them, the presenters, that, because, and you could probably take note of this. I think the way it's going, there's going to be a resume of videos. Like, you're going to have a resume of videos that you took part in.
Okay.
It'll be just like a resume. It means something because I think it'll get have more and more value academically as time goes on, as it gets better. Now we're kind of inconsistent with the audio and stuff like that, but we're getting better. But to reach a point where it's really like, actually, I'm going to get paid for that conference because it was good. And that was good news to hear. But we've got to get consistent with sound, because as you know, sometimes the sound goes out and inconsistent video. So it's really hard to to charge for something like that. But it'll not only get profitable for me to do it, but it'll get more valuable academically. Academically, it'll take its place amongst books and podcasts and other things to have value. So.
Yeah, it's absolutely a good reference and a fast reference. For example, the work the young African neurosurgeon did was amazing. They create a sort of video neuroanatomy.
I know those guys really go all out, man.
Yeah, very smart.
I asked them. I said, you don't have to. I mean, to make an hour presentation, Marco, that takes a while to prepare and to be a student to do that.
That's right.
That's I just said, cut it down just 20 minutes, but they want to do it, so that's fine. Okay, if you want to do that, that's fine.
Absolutely. We don't ask for a marvelous, very elaborated presentation. Just scholastic, simple presentation, but a manner to talk about the topics, to share experience, and all around the world. We can say that.
Yeah, I'm glad they're doing it, but they're really taking it seriously. Students of today, you got so many tools to use. You got to kind of pick the tools that you like. You can't use everything. There's so much out there that, but we're getting better. So, okay, guys. Thank you very much. Oh, I think, is there someone else in here? No. Okay.
You are.
Yeah, like I said, the African one is the next one, and we have a couple of pediatric neurosurgery. You guys aren't into that, right? We have one from India we're doing, but conferences will come up from people like you that say, hey, why don't you televise it? And that's how we get most of our leads, was people that like them say, hey, let's try it. So anyways, okay, very good. Thank you. You guys have a great day.
Have you too, John. Thank you very much. Bye, Adnan. Thank you.
Okay, Adnan, thank you. Bye-bye.